Today we're going to be talking about remote patient monitoring, real-world implementation. Before we get started, I just want to throw out a reminder for everyone that the CTRC is vendor neutral. We are funded by HRSA, so everything that we discuss today is just for informational purposes. We're not here to provide legal advice, and we are definitely not here to sell you on anything. So all of this is just for your own information and not to sell anything. More tips for today. You all have been muted upon entry and your videos off, but please feel free, though it is your lunch break, feel free to join on camera and be on live with us. Use your video. Feel free to use the Zoom chat to note your comments, make any questions for our presenters today. We are recording this session, so that is your warning. You are being recorded. We will post the recording of this session on our the CTRC website by the end of the week. And you can rotate between speaker view or gallery view to see all the beautiful faces in attendance today. For those of you that may be joining the first CTRC webinar for the first time, we just want to let you know that CTRC has been around since 2006. Our mission is to provide unbiased, no-cost telehealth resources and consultation and training, all to support telehealth providers and patients in California to get the most out of their telehealth programs. CTRC is a part of a national consortium of telehealth resource centers that together serve the entire US. So we have a big brain learning collaborative shared between us. And we are also part of the OCHIN family of services. So we exist to just support telehealth in the state. So for today's session, I'm going to be introducing our awesome guest presenter, Megan Bowen, and she's going to be taking over from here. Megan, the floor is yours.
Great. Thanks so much, Aislinn, and thanks, CTRC. I'm happy to be here today. Hi, everybody. I'm Meg Bowen. I'm a practice coach with the transformation team at OCHIN, and I've been with OCHIN for about 3 years now. Now, prior to joining OCHIN, I was the quality director at a large frontier FQHC here in Northeast Oregon. My entire career has been spent in healthcare. I jokingly say it's been my longest relationship. And my areas of focus and interest, I saw your laugh, Joey. My areas of focus and interest include remote patient monitoring, patient-centered medical home. I'm an NCQA, CCE, SOGI data collection, quality improvement, and population health. So I'm calling into you today from my home in the mountains of Northeast Oregon. So thank you so much. Next slide. Great, so here's our agenda for the day. We're going to go through an introduction and RPM overview, talk about how to build your team, assess, plan, and identify your clinical use cases, test, refine, and implement your processes, and then how to grow your program. Great. And next slide. So great, RPM introduction and overview. So RPM is basically using connected digital tools to electronically capture health and medical data for care team review. It's pretty simple. So as healthcare moves from a fee-for-service model to a value-based approach that rewards performance and outcomes, remote patient monitoring is helping to accelerate the transition from our episodic reactive care delivered in that clinical setting to continuous proactive models that blend in virtual and in-clinic care. So patients can use medically prescribed RPM devices in the course of everyday activities to collect and transmit their biometric data, such as blood pressure readings, blood glucose levels, body weight, heart rate, respirations, and temperatures directly into the electronic health record in near real time. These data sets then give a detailed and nuanced view of the state of the patient's health as it fluctuates over the hours, days, and weeks, enabling providers to deliver more personalized care characterized by frequent minor adjustments. Subtle changes in the data can trigger intervention sooner in lower cost settings, which supports the quadruple aim. So launching an RPM program within a medical practice is complex, I'm not going to lie, and involves not only choosing the right technology, but selecting the right patients and the right parameters and developing the right atmosphere within your practice. There's a lot of planning that goes into the process long before your go live date, and a lot of work that goes into making sure that the results meet your expectations for both patients and your clinical staff. Continued and steady success can lead to sustainability of this program, which in turn can pave the way for scalability. Next slide. So RPM is a tool to help address health equity, but it is one that requires patient engagement, and resistance to RPM is often tied to barriers, whether they are real or perceived. Now that's resistance on behalf of patients and staff. Did you know that 75% of Americans struggle to take their medications as prescribed? Patients' well-being is being jeopardized, and the healthcare system is losing billions of dollars due to this noncompliance. Accordingly, drug non-adherence causes nearly 125,000 deaths annually in the United States and accounts for 33 to 69% of medication-related hospital admissions. The overall cost of drug adherence alone is estimated to be between $100 billion and $300 billion every year. So with RPM, patients have agreed to adhere to their maintenance and treatment plans, right? They're a partner in their care. This is to avoid calls and notifications from providers whenever they miss taking their medicines or fail to measure their vital signs. Every failure to keep up with their treatment and maintenance plans is being monitored by RPM. But we'll talk more about compliance and patient engagement shortly. Additionally, studies show how patients enrolled in RPM enjoy using their devices and look forward to using them every day. This is called gamification. Patients are also educated and guided with the indications of each result that they see on their device. For instance, the color green that they see on their mobile app every time they measure their blood pressure indicates that it's within a normal range. That's great to see. To maintain that color green, patients must adhere to their maintenance treatment plans and take their medications on time and also do their daily exercise. Next slide. Great, building your team. So in building your team, think about workflow development in your organization. How does that occur now? Does someone sit in an office by themselves and complete the workflow? That's not how it works. You need to have input from all, well, you can do it that way. It doesn't work very well, but you need to have input from all staff that are involved in the process, everybody that has a touch point along that process. So you need to identify your stakeholders. Who will all be involved? Front desk, rooming staff, clinicians, care team members, maybe community health workers. There are a lot of different folks who are going to have touch points along the way. Grow your champions, recruit and grow champions from your own ranks. Who's really interested in this work? Don't just pick somebody that's a gamer in your organization and assume they're going to have all the technology needs that you need to make this work. Now, grow your champions carefully. Make sure you partner with patients. How do they feel about it? Build on your previous successes and designate an RPM coordinator. That is the person where the buck will stop. It won't stop with a clinician, it will stop with this RPM coordinator. So technology may be the underpinning of a successful RPM program, but that success won't happen without a trained and motivated staff, one that understands what's necessary to make this program work, and above all else, keeps your patients engaged. Before getting into RPM, a practice must make sure that everyone is on board with the program. It will mean changing your workflows and responsibilities. Gasp, I know. And that means training everyone ahead of time so that there are no surprises. This is especially important for nurses and our rooming staff who will see the data coming in from the RPM programs and interact with patients more frequently than clinicians. Those folks will need to understand not only how the system works, but how they make it run better, including when to talk to patients in the program and how to keep them engaged. So they're also responsible for identifying those emerging concerns that require clinicians' intervention. So we need to keep our patients engaged with this program, and RPM programs won't work if the patients aren't invested in the outcomes and interested in helping to manage their own care. Bottom line. This is the patient becoming part of the care team. It's as simple as that. You know, in our patient-centered medical homes, everybody circles around the patient. Well, this is an opportunity for the patient to actually be a part of that circle of their care team. In short, remote patient monitoring platforms aren't solely about just gathering data. They're about connecting with patients to see how they're doing, helping them with their plan of care, and giving them support, guidance, and resources to improve their health and well-being. Remember, our patients only spend 1% of their lives with us in clinic. It makes sense that we get to view how they spend the rest of their 99% of their lives. So, on to the next. Perfect, thank you. So assess, plan, and identify our clinical use cases. So infrastructure. Does your community have robust broadband services available? Let's think about patient readiness. Do patients have sufficient broadband needs, or broadband speeds in their home? Smartphones and reliable data plans? What about language needs for your patients? What about those patients that have a month-to-month subscription phone? Think about organizational readiness as well. Does your health center have adequate budget and resources, staff, equipment, expertise, and training to implement, maintain, or expand an RPM program? Legal and compliance. Are providers properly licensed and insured to offer RPM services? Are provisions in place to ensure RPM data remains secure and private? What RPM services are billable to your payers? What are the rates of reimbursement? What are the indirect costs and savings then tied to RPM? Do you have staff and staff policies in place to make RPM useful and adopted by your patients? So, do you have communications in place? Do you have standardized messaging or scripts to support staff as they explain the benefits of RPM to their patients? Do you have prepared frequently asked questions for common patient questions about data privacy and security? These are things that you will grow as you grow in your pilot. Operations, do you have support from the operations side to make room for this project? What other things do you have going on? Do you have a HRSA site visit coming up? Do you have a medical home? What else is going on in your organization? Do you have staff and patient policies in place? And do you have a plan to test, develop, and standardize your RPM workflows? So a critical piece of the assessment and planning includes thinking through the steps to protect the privacy and security of your patient's RPM data at every point of the journey, from the device in your patient's home to your EHR. And did you know that the Children's Online Privacy Act, it's called COPPA, requires the consent of a parent or guardian before collecting personal identifiable information from children under the age of 13. So CTRC has a great assessment, and I'm going to drop the link into the chat for you. This is a tool that you can use. It's on the CTRC website. It's a great assessment for you to use if you're looking to get into RPM or you're looking to scale up. Okay. Next slide. Perfect. Now we're going to identify our use cases. So assess, plan, and identify our clinical use cases. So we have, so think about our use cases for patients that are well matched to the needs of our patients in our center. So think about it. So what kind of RPM data do your clinicians want to see and need to inform their clinical care? And what kind of data can we get from our patients? So one useful starting point is to identify areas where RPM is already being used in your practice. Think broadly and include informal applications as you take inventory. So for example, maybe my organization doesn't have RPM, but I have a flow sheet that I can enter my self-reported blood pressures in. What does that tell me? That tells me that the patient is engaged enough, the patient has a cuff, I'm engaged enough, I'm taking my blood pressures, and I'm entering them into the flow chart. Now, whether or not those qualify for UDS is a whole nother story, but can my provider use those for clinical decision making? That's a good case. That's a good case to take the next step and move to remote patient monitoring. So, set measurable goals that will guide your health center's RPM program from a starting point to an ideal future state. So that means capturing your baseline rate. Say you want to launch self-measured blood pressure project with patients in one panel only. What are your goals? Is your goal that they can connect? Is it your goal that they can transmit data? Is it your goal that that a timely response is given from the care team if there is a question about the data that's transmitted? Is your goal the change from baseline in the control data? So what's your overall blood pressure reading for patients in a pilot? Track that. So there's lots of different incremental steps that you can take. Just don't go right to your ECQM of, oh, we're going to launch RPM and we're going to see improvement in our ECQM for blood pressure control. Think about all the different incremental steps and work your way up from that. So think about what your success measures are, and think about too for success measures for your staff. Now, RPM has primarily been used for chronic disease management like glucometers and blood pressure cuffs, body weight scales, pulse oximeters, for treatment of conditions like hypertension, home management of COVID, congestive heart failure, and COPD. A good rule of thumb is to choose a population that's costing the practice a lot of money in unmanaged care expenses or hospitalizations, such as those with uncontrolled hypertension or diabetes, or those who treat the ER as a primary care resource. We know who those patients are. These are patients who would most benefit from remote patient monitoring and who would show measurable results through adherence to prove the program's success. You've got to measure what's happening. So just think about that. What are you going to measure? So what are some other cases where patients could be sharing or transmitting data from home recordings that you want to incorporate into their plan of care? So it could be mental health monitoring, could be a lot of different things. So just think about that. Whoop. I'm cutting off a lot. Okay, is anybody, Aislinn, are you hearing it cut out? No? Okay. I'm sorry. Okay, good. Okay. Wonderful. Super. So choosing and distributing our RPM devices. So you have identified clinical use cases for RPM. The next step is to really select the RPM device for use in this clinical application. So when it comes to RPM devices, the market offers just a staggering number of options, and every day there are more and more and more. How do you choose the best RPM device for your health center? Well, without a doubt, start with your EHR vendor. Some offer kits or bundled devices specifically tailored to conditions. So, and some even will ship directly to the patient home and have approved patient-facing information. I mean, how great is that? Now, of course, you'll need to confirm with billing whether your payers stipulate specific RPM devices for reimbursement. And remember, multiple RPM devices increase the complexity for staff and your patients. Okay. Next slide. Let's talk about rates and codes. So the Department of Healthcare Services views telehealth as a cost-effective alternative to in-person healthcare, particularly in underserved areas. Remote patient monitoring is assisting in the transition from episodic reactive care, as we said before, delivered in that clinical setting, to a continuous proactive model that integrates virtual and in-clinic treatment as healthcare shifts from that fee-for-service model to our value-based approach. Based upon performance and outcomes. So every year, CMS releases the new Medicare physician's fee schedule that outlines billable activities as well as reimbursement criteria for the coming year. So CPT codes and criteria for RPM services can be found in the publication once a year. And RPM services rendered to established patients are reimbursed under the codes of 99453, 454, 457, and 458, and also 99091. To guide California healthcare providers in RPM billing and reimbursement, these are the Medi-Cal rates that have been updated are in effect as of March 15th of 2022. So let's go through these. So our CPT code 99453. Healthcare providers may get reimbursement for the onboarding and education of patients as the CPT code covers. It's a one-time cost that your providers can charge for enrolling the patient into a new remote patient monitoring system. The CPT code includes the time spent in setting up the system, educating the patient how to operate the system or the medical device, and any other services that might come along. CMS does not reimburse for this equipment, or reimburse for the equipment, just the time spent with the initial setup. And this code was designed to assist patients with the usage of devices and compensate your staff for training them. So code 99454, this code allows healthcare providers to bill monthly or every 30 days. It's a code for the cost of leasing home health medical devices to the patient and the software or the mobile application used to run the RPM service. The device should not be previously owned by the patient, but instead should be provided by the healthcare personnel. The device must only be used for home care and needs to automatically upload the data to the provider on a daily basis. Now, CMS provides clarification that this code requires the patient to submit at least 16 days of device readings during that 30-day period. So a patient may have multiple RPM devices, but healthcare providers can only bill once per patient per 30-day period, and only when there are 16 days of patient-generated data that has been transmitted, even when many devices are given to one patient. So what's the key here for this code? Patient engagement. 16 or more per month, right? Patient engagement. The patients need to understand they're the trigger for all of this work. So next CPT code is 99457. Now this code refers to RPM care management services spent with a minimum of 20-minute duration in one calendar month by a healthcare provider. It could be a physician, could be clinical staff, or a qualified healthcare personnel. Clinical staff includes, but is not limited to, registered nurses or medical assistants. It's subject to scope by state practice laws, okay? And the supervision requirements included in that applicable law. So this reimbursement covers the clinical time used for monitoring a patient's health data and interactive communication with a patient through the phone, through a text, through an email, or through your portal. Example of patient's health data: blood pressure, glucose level, pulse rate, and weight. This code is billable once per month, regardless of the patient's condition. So this is a 20-minute duration, and it includes one interactive communication with the patient to let them know, hey, we're getting your readings just fine, everything looks great, or not. So CPT code 99458, this is an add-on to the 99457. This is when you get to include an additional 20 minutes of time every month, and that's for that additional time. It cannot be billed as a standalone code. It must be billed with the 99457. Okay. So, okay, does the PE temporarily change some requirements on the usage for the patients? That's a really good question for the public health emergency. That's a really good question, Gideon. I'm going to grab that answer for you. So thank you very much. So CPT code, the last one of 99091, it covers standalone collection and interpretation of remote data. So that includes 90 minutes of clinical time between the patient and physician once a month, and requires at least one instance of communication, which can be a video call, or excuse me, a call, a video visit, email exchange, or portal message. So great. Okay. And then on to the next slide. Let's talk about remote therapeutic monitoring codes. So what's the difference between remote therapeutic monitoring codes and remote patient monitoring? So remote patient monitoring is the use of our digital technology to capture and analyze patients' physiological data, such as blood pressure, glucose levels, lung function. By contrast, remote therapeutic monitoring focuses on non-physiological data, such as patient adherence and reported pain levels. With remote therapeutic monitoring, the patient doesn't necessarily need to use a device. You can simply need a platform that's able to track quantitative and subjective data from your patients. And there are many ways to collect that information, including software, a web portal, mobile app, or even from a wearable device. So these are the RTM codes that you're seeing here. So this is from the 2022 physician fee schedule. So CPT code 98975. This is that initial setup akin to the one we saw before, but this is for remote therapeutic monitoring. And then there's the 98976. This is for therapeutic monitoring for respiratory system status, or musculoskeletal therapy adherence, therapy response, pain scales, things like that. That's every 30 days. The 98977. That is actually excuse me, the first one was 76 is for respiratory system, 77 is for musculoskeletal, and then the 98980, that is the therapeutic monitoring for providers within a calendar month. So that allows for the communication. It's the first 20 minutes of the code, the 98981. That's an additional 20 minutes that we saw previously. And so yeah, there's a lot of information out here about remote therapeutic monitoring. Would the 98975 be charged when the patient comes in for the office for training, or also done remotely? Yes, absolutely. You can do it remotely as well. Okay, super. And there's a link to the slide here to the physician's fee schedule page at CMS. Next slide. Let's talk about a digital formulary. So building your digital formulary. Once you have identified the RPM devices that are compatible with your EHR, meet the requirements of your payers, you may want to narrow your choices down further on the basis of cost to the patient or additional cost to the patient, the ease of use, the battery life, the protection of a HIPAA BAA with the RPM vendor, or other criteria. Work with your EHR vendor to package your selections into a digital formulary that your EHR can potentially streamline for prescribing. Okay, so think about that. Just like some of us have 340B pharmacies, think about a digital formulary. So BYOD, that is bring your own device. So even if your practice opts to create a digital formulary, there could be certain instances when it makes sense to consider RPM devices or apps selected by your patients. You may have some patients that can benefit from clinically appropriate devices or apps that are not in your formulary. This is so-called bring your own device approach, offers patients the flexibility to really collect their own data with devices or apps that they're comfortable and familiar with. Your practice may elect to adopt a hybrid that utilizes both a digital formulary and validated devices and, a digital formulary of validated devices and a BYOD model for certain use cases. But be aware that BYOD models are more prone to compatibility issues with the EHR. In addition, BYOD training and technical support may be outside of the scope of your RPM program. Think about who might be able to troubleshoot that device if there's an issue. So one important thing to note, if you do go the BYOD route, make sure that the device is functioning as expected and have the patient bring it into the clinic so it can be calibrated against the office machines. Don't go to all the effort of setting up this BYO device if you're not sure. That their own personal device is functioning correctly. I know it seems simple, but don't forget that step. Next slide. Budget considerations. So once you have identified your clinical use cases and prioritize them based on your health center's needs, work with your stakeholders to make sure that it's compatible with, work with your stakeholders and your team to select an RPM device that is compatible with your EHR needs and meet the criteria that you have, like the cost per patient, ease of use, quality of data. At this point, your financial champion and executive sponsor should have adequate information now to develop a budget estimate for what this pilot will look like, as well as projections for scaling up and maintenance of those RPM services in the future. So here are budget items to consider for your RPM program. What are the EHR vendor costs for build, installation, testing, training, maintenance, and fees? RPM device vendor interfaces, training and maintenance, hardware and software costs, any operational costs, any communications costs. What about costs for patient engagement? And what about staffing? So make sure that you think about these when you think about your budget. And on to the next. Great. So test, refine, iterate, and repeat. So test, refine, iterate, and repeat as your health center moves from assessment and planning to testing and implementation. Change management and quality improvement frameworks can help provide structure for your team's activities. So let's think micro pilots to start. For example, start small with your simplest clinical use case, really small. So think about hypertension. Think about, do you have 10 patients in your organization that you could send a Bluetooth cuff to and have them transmit for 7 consecutive days for BID readings, for twice a day readings? Think about that. That's the kind of pilot we're talking about, micropilot. Or remotely track body temperature and oxygen saturation levels for 25 patients in the EHR for maybe a week or 2 weeks using a wireless thermometer or wireless pulse oximeter if those are the things you're going to be measuring. Or for thinking about diabetes control, recruit 3 patients with diabetes who use a particular brand of continuous glucose monitor to transmit blood glucose levels daily to the EHR over a period of maybe 3 weeks to 4 weeks. Remember, do not overwhelm your staff or your patients. Start small with your pilot and scale up. Choose one of the 3 options, not all 3. Choose one of the 3 options, and then you can always scale later. Make sure you have your baseline data to support your efforts. How else will you monitor change? Think about this with your QI lens. As I mentioned earlier, it's a stepwise approach to measurement. So what's the baseline of the clinical quality measure we're trying to move in this population of patients in the micropilot? Are we trying to move the CQM? Are we just trying to get our patients engaged and have another view of their blood pressures or their glucose throughout the day? Is the patient able to set up the device and transmit data? Is that going to be one of your rubrics to measure by? Or what's the frequency of transmission? Lots of different things to measure here. Okay, great. Next slide. So policies, protocols, and workflows. So ensure your policies address compliance with legal and regulatory requirements, patient safety, technology capability, compatibility, terms of use, hours of operation. What can the patients expect if they wake up and take their blood pressure at 2 o'clock in the morning and their blood pressure is high and they submit it? Is there anybody in the office that's going to see that? So think about the hours of operation. A follow-up time to review and to respond to the data. What does that look like? And efforts to minimize the provider burden. We're going to talk more about that in a couple of slides. So it's important to establish clear policy and protocol around patient terms of use for your RPM program. For example, patients must grasp that this type of remote patient monitoring is not intended to manage urgent or emergent conditions. If they wake up in the middle of the night and they've been doing their RPM for blood pressure and they wake up and they're short of breath, the patients need to know what to do. They need to know what steps to take. So make sure that you share widely information about RPM through your patient portal. Waiting room screens. Many of us still have television sets in our waiting rooms that we cycle through different information. So think about putting information there about workflows and policies and procedures for remote patient monitoring. Think about your call center scripting. Think about printed collateral. Think about a quick help guide. What would that look like? Make it very easy to follow. What is your threshold for connecting to immediate medical attention? What's that threshold going to be, and to get that established? So patients using RPM devices registering abnormal values in an unsafe range should be advised to go to the ER or call 911. What about a patient contract or a compact? Has anybody explored that idea with your patients yet? That is something that we did when we signed out blood pressure cuffs. The patient actually signed an agreement that they had a responsibility in this, and we had a responsibility as well to them. Seemed to work pretty well. So one other clinic I've worked with used their CHWs in a very innovative way. So they were currently screening for SDOH, and during the height of COVID, they also launched RPM to help close those gaps in care as patients stayed away from clinic, right? So this organization trained their CHWs to be able to go into the home. They were going to be there anyway, to troubleshoot, observe the patient with how they were seated, if they were seated properly, and then having that on the ground help desk. It was a fantastic use of the CHW resource and helped with connecting with the patient in more ways than one. It was really valuable to have the eyes on the ground, having the CHWs trained to do that work. Okay, reducing clinician burnout. I said we're going to get here, and here we are. So what about RPM and its role in reducing clinician burnout? Now, initially you may be thinking, how is this going to reduce clinician burnout? Seems like it would add to my burden. Well, it's important to acknowledge clinician concerns related to managing large volumes. Perceivably large volumes of RPM data, chiefly worries about increased workload and potential patient safety issues related to inadvertently overlooking small bits of RPM data. So when developing your policies and processes, think about opportunities where your nursing or your rooming staff have standing orders. Think about that. How does that work in your organization? This helps remove the burden from the clinician, but they're kept in the loop with how the patient is transmitting the data. Think about the rooming process. How can huddle scripts be changed to include information about how RPM is going for your patients? How about adding some kudos? We've been seeing that you're transmitting your data. This is absolutely fantastic. Thank you so much. So here are some strategies to help reduce clinician burden. So clinician-friendly policies and workflows. Use your good team-based care approaches for this work. Get comfortable with your communication about patient transmissions and the next steps. Has anyone used email pools that go to a triage or nursing staff to review incoming values? So think about technology optimization and automation. Use as much technology as your team, including your patients, are comfortable with. And think about intuitive user interface designs. When we're looking at our different types of devices, think about those interfaces. Think about it with your patient hat on. If I was a patient, would I be able to understand what this machine is trying to do? This is for both the patients and the team. So the 5 rights of clinical decision support are a useful rule of thumb to guide your team as you design your workflows to minimize your provider burden as you map out the flow of RPM data from home to EHR. Keep in mind, we need processes that deliver the right information to the right person in the right format via the right channel at the right time in the workflow to inform clinical decision making. So ideal workflows maximize ease and convenience for patients and minimize clinician burden by furnishing the right data at the right time to best inform clinical decision making. Okay. So next slide. And workflow development. So workflow is simultaneously one of the most important and challenging components of RPM integration. A user-centered approach to workflow design takes the perspective of each stakeholder. Remember all those people I talked about with workflow design? All those people that are involved, staff, clinicians, patients, and others. It is the workflow, that workflow, which will unite the technology, the culture, and the human factors that will make your RPM integration successful. So starting with prescribing the RPM devices, prepare your care team, patients, and other stakeholders to really broadly think about all the different steps needed for both patient and providers to be well supported in this journey. Now determine which roles will be responsible for accomplishing each detail. Keep in mind that an idealized workflow can lead to problems. A user-centered approach can help the team stay grounded. Process details to consider. So set safety ranges for patients and staff and communicate them. Determine who will instruct the patient. The patient needs to really have a single point of contact, and that should not be the clinician. Also know your population. Just because someone is a gamer, like I said earlier, there doesn't mean they're going to be able to instruct your patients on how to use RPM devices. Just because they're tech savvy, they may not be able to do that. So determine how the data will be collected and transmitted. Is anyone considering notifying patients of received values during the pilot phase? So let's think about that. Let's think if we have a 2-week pilot or maybe a 1-week pilot for blood pressures. At the end of day 1, you expected to see transmission. Did you see transmission? Great. Would you want to send a note acknowledging to your patients, hey, it looked great, thank you so much. That is going to encourage them rather than them sending off a value into the great unknown, right? So just think about that. Think about what you might need to do on the staff side to reinforce this behavior. So who reviews this incoming data? So develop a method for routing the data to providers, communication about issues and or update what's currently happening. So think about what I said earlier about huddle scripting. So when you do your huddle prep, think about what your patients are doing, think about how you can gather that information and use that in your huddle script to inform your provider of how things are going with RPM. This patient's doing great with RPM. We're getting all these beautiful blood pressures. So, well, who's going to troubleshoot that device? Remember the CHWs I spoke about earlier? Well, during the pandemic, many rooming staff found themselves in the role of instant IT for telehealth. Not only for the patients, but for other staff as well. So rethink that approach. It probably didn't work out very well for many of you, but maybe it did. But make sure you have an escalation plan in place to support your staff and your patients. Make sure that your rooming staff know that there's somebody else that they can go to that has the answers. And the next slide. So rapid cycle tests of change. So please use your good QI processes to test, refine, and iterate. And think in days, not months. And use good framework like PDSAs to keep yourself on track. Remember to monitor and incorporate those efficiencies as you streamline your process. You're going to learn so much as you go through good cycles of change. And the next slide. So, how to grow your program. So congratulations, you've made it through your pilot. You've completed that pilot testing. You've rolled out your workflows. Your patients are transmitting data, and your team is able to confirm and make clinical decisions about care. It's a success. So you are billing for those services as well, and it's also going well. So what now? Now it might be time for you to scale up your RPM program. It's also time for your champions, particularly your clinical champions, to really shine. Clinician champions are often the most visible and influential members of your team. So trusted by colleagues and patients alike, they can really make a substantial impact as they tout the benefits of this RPM model by including their attitudes and behaviors around it, and they can raise excitement around using RPM in routine care. Leverage their expertise to tailor instructional materials for your practice. Great. Communication. RPM priorities and concern differ for staff and for patients. Top issues for staff include the evidence base for RPM in treating common conditions, how to ensure patient safety, and ways RPM might impact their workflows. So your communications champion will take the lead in creating an RPM promotional campaign for staff and a separate RPM campaign for your patients. Just as the team took a user-centered approach to create RPM protocols and workflows, plan communication campaigns with needs of your target audience in mind, and bake this approach into your training methods. For example, other staff opportunities to practice RPM workflows with a variety of test patient scenarios. Include as part of your staff training simulated experiences with RPM technologies from the patient perspective. Encourage staff to use RPM in their personal care. One organization I've worked with in the past, they took the whole first year of a hypertension project to get their staff blood pressure under control by practicing good techniques, using evidence-based approaches, and all the while gaining powerful buy-in in the project because the staff were the patients at that time. The staff had experienced or witnessed the power of the intervention and were eager to share it with the patients, and they were very powerful proponents. So think about your staff. Start with your rationale for RPM to kick off staff training. Use your team's rationale statement to explain why RPM makes sense now for your health center. It may be useful for staff to understand that getting started with RPM lays the foundation for your health center to offer leading cutting-edge care in the future. So build on this by incorporating trainings that address the what and the why and the how, so the staff can see the big picture of RPM and how it supports quality patient care and clinic efficiency. Recent studies find that it is important to designate technical training and support responsibilities to non-clinical staff. Leverage these designated staff for key roles in developing training materials and developing patient-facing materials as well. So use similar standardized messaging to develop patient-facing scripts for front desk, clinical support staff, providers, and other staff who interact with patients along the RPM touch points. These provide the continuity that supports new cultural norms, and it allows your staff to practice in a safe space with their colleagues. It can be useful to frame RPM for patients as it is now their provider's main and standard way to deliver certain types of care. At first, staff might find scripts, they might be using the scripts verbatim, but each staff member will adapt their own style to their own personality and the patient's needs as long as the content is consistent. Okay. ongoing training and support. So develop training programs in parallel with communication campaigns. It will be necessary to create separate training and technical support tracks for staff and for patients. Use change management strategies to structure the rollout of your RPM training program. Introduce opportunities for staff and patients to learn about the benefits of RPM, and develop the skills to use RPM well in clinical care. Through ongoing reinforcement, we adapt attitudes and behaviors that support that lasting cultural transformation. Pretty soon you're going to be, well, this is who we are now. This is what we do. Store RPM training documentation in a centralized location and ensure all staff know quickly how to locate it. Next slide. Great. Health equity and RPM. So your first rule of thumb is to train staff to offer RPM to every patient who can clinically benefit. It's a mistake to rule out RPM based on factors such as patient income, age, living situation, or education. These patients may be your ideal candidates. And if some of your patients are facing barriers to using RPM, have ready solutions to help them use the technology successfully. And as you start to implement this, you're going to hear about different barriers. And as you discover those solutions, add that to an FAQ document. So the next time that barrier comes up, you already have the solution at hand, and make sure that's spread among your care team. So to eliminate biased judgment, it may be useful to routinely survey all your patients about their preparedness to use remote patient monitoring. Consider folding questions into internet connectivity, into new patient intake forms, or maybe even annual social determinants of health screenings. Just a consideration as we move forward with RPM. Okay, maintenance and sustainability. So if possible, give staff hands-on experience with RPM devices you'll be prescribing. Invite staff to stand in the shoes of your patients, to understand the patient experience as they become acquainted with these new technologies. Encourage staff to use RPM in their own personal care. Now, when thinking about this, I think in my mind about a pod setting, and I'm going to hand a device over to one of the rooming staff and say, can you figure this out? Don't do that. Have them in a separate room by themselves. That's how the patient's going to be at home. The patient is going to have a whole bunch of people standing over them, helping them set it up. So have your staff member really walk in your patient's shoes to anticipate some of the issues that your patients might come across. So again, set measurable new goals as you evolve. Remember, one of our first goals was, are we even able to transmit? Are we even able to transmit? Great. Okay, that was a really tiny goal. It goes up a long way to getting to our ECQ of better controlling our hypertension rate. Get feedback from all stakeholders. How's it working for patients? What about their caregivers? What about family members? Talk about it during upcoming face-to-face appointments or telehealth appointments. And then share success stories. Share success stories. That is one of the most critical things to do, to think about with communication and with sharing that information. So success stories go a long way. So think about where you can share those. You can share those with your patient and family advisory council. You can share those with your clinical boards for FQHCs. So lots and lots and dots of different opportunities to share your success stories. Okay. And on to the next slide. Great. So we're wrapping up now, and we have some time for some questions. I see there's a couple of questions in the chat, and we also had some questions that were submitted ahead of time. Let me see. So there was a question that came in ahead of time. Review the scope of RPM interventions and reimbursement pathways. So I'd already dropped the technology assessment link into the chat, but I'm going to actually do that right now again for you. So this is a really good resource for you to have. Great. Super. They're a group resource that has information specific for FQHCs. Oftentimes payment is different and then what's allowed is different. Even the codes are different. Okay, some of these codes roll up into NEG codes. Absolutely. That's a really great question. We're going to take that one back to the CTRC team and we'll pull together information. I see there's another one too for the unique codes for billing RHCs and FQHCs. So absolutely, we'll put together a little document for that for you, Gideon. we'll be able to supply that for you. What other questions might folks have? And I can also go to the questions that came in beforehand too. Or comments.
And while we're also waiting for some more questions to come through, I'm going to go ahead and launch a poll just to get some feedback on today's session. So please continue to drop your questions, but also click and let us know how you like today's session. And I do want to say for those looking for reimbursement advice, CTRC just did release a updated version of our telehealth reimbursement guide that does have information for FQHCs and RHCs that definitely is worth checking out. Yeah, it's updates.
I just dropped a link into the chat. This is for the Telehealth Program Developer Toolkit. It's currently out on the CTRC. Okay, given that this can improve patient outcomes and reduce cost, are you familiar with any payers providing these devices to patients at no cost? I am, but those are usually funded through grant opportunities. So that's where you get your grant writers going. So the patients can get these devices at no cost. And at the height of pandemic, there were a lot of opportunities out there, and there still are some opportunities out there. So how do you get the information that she just mentioned that has the FQHC payment information? Aislinn, do we have that link that we can drop into the chat? Perfect. Thank you. So if anybody has experiences with RPM that they'd like to come off of mute and share, you're more than welcome to. Any frustrations, challenges, things that worked really well for you? Okay, I have another bit of information I'm going to drop into the chat. We had a question that came in. It says, what are the requirements from RPM? Who needs to order that? So I have that for you. Those are the criteria to bill for RPM. Yep, and then there was another question. I wanted to know if California is eligible for reimbursement. Absolutely. I think this is the older 2020 guide. I think, Aislinn, are you going to drop the newer one?
Oh,
great. Super. Great. In my experiences, what are the biggest challenges with RPM implementation on the care delivery side and the patient side? What are some ideas to address them? So absolutely. So on the care delivery side, I think it's the big challenge of who is going to own this hot potato of the technology. It's called techno stress is what they're calling it now. So who's going to own the hot potato of that technology? And we saw that during the height of the pandemic. A lot of that landed on the shoulders of the rooming staff, which sometimes didn't have the technology background in order to support this. So really outlining who's going to do what and then who's supported in that role is really, really important for your care teams. Now on the patient side, connectivity, I think, has been one of the biggest things that we've seen in the past, that patients are struggling with how to get it connected. In some areas, we may not have robust broadband services available to us. There are grants and things available that you can apply for, especially in those frontier and remote locations, that will help offset that. Okay. And again, for the patient side, what are some ideas to address them? Create your patient-facing information and then make it easier again. When you think it's easy, make it easier one more time. Think about who your population is. Do you have a patient and family advisory council? Awesome. They're going to be a great sounding board for this kind of work. Absolutely. Absolutely. So any other questions? You're welcome. Okay. Yes, and the slides will be provided by the end of the week.
yes.
And the recording? Where will the recording live?
We will share the recording. When you registered and provided your email, we'll send an email out to you by the end of the week. That includes the recording, the slides, all of that information, and it will be posted on the